Hi, everybody. Dr. Lee Coleman. As always, very happy to see you here. I want to talk to you a little more about what I really consider the heart of what we're talking about. So, psychiatry and society is our topic. So that means really thinking as deeply as we can about what is psychiatry and what does it do in society. I said way in the beginning of these sessions that that if I was going to be critical of the role that society played in our society, as I was and am doing, we were not going to put all the blame on psychiatrists. You might remember that I pointed my finger at you and said, you are the ones who are just as much to blame. And then I pointed the finger at myself because I'm in society too. All of us are part of the society, and we have given psychiatry the role that it has because we want them to be doing what they're doing. Now, I'm not ready to let them off the hook. Psychiatry accepts what we want them to do, but we all have asked them to do it. Well, if we want to reevaluate that, and you know that's my view, that we need to do that, we need to do the most thinking about where is the real heart of the problem. And the heart of the problem is psychiatrists don't practice medicine, they practice something else. Now, that doesn't mean that there's nothing that they do that's not medicine. There are things that they do that are medical because they are trained as medical doctors. You know that. You cannot be a psychiatrist unless you are trained to be a medical doctor and you are licensed to practice medicine. And the training, you know, I don't agree with much of the training, but I don't disagree with all of it. We learned a lot of medicine when we go to medical school, and then you practice the things you learn on patients. And there is a role for the medical training that psychiatrists have. But I think where the difference, where they begin to part ways, is our expectation that they are legitimately a part of medicine in all of the things that they do. And that is, of course, what psychiatry desperately wants us to think. As I've explained, it was when psychiatry was threatened with a major loss of its power and prestige starting in the 60s that we began to see the emergence of this medical model. Psychiatry developed that medical model as a way of defending itself and promoting its new image, not because of any scientific developments, because the then claims that they made have not been real. They have been demonstrated not to stand the test of time. So in this session, I want to talk what I consider right in the heart of darkness, as I said before, and that is the concept that we diagnose patients and then treat the diseases that we have diagnosed. We don't do that, as I've talked at some length, so I'll try not to just repeat myself, but I want to pick it up and talk about how diagnosis, pretend diagnosis in psychiatry, leads to pretend treatments and actually sets us back. Our society would be better off, and psychiatry would be better off, if we, rather than being afraid of the lack of diagnosis and the lack of these medical treatments, would embrace the fact that we cannot diagnose because we are dealing with a different kind of subject. Studying some aspect of the body and the physiology is not the same as studying the mind. Now, we know that the mind resides in the brain. Of course it does. But it's not the same as saying that we can study it in the same way, because the brain is so much more complicated than the other parts of the body. We're talking about a physical system which has so many interactions in the different parts that to try to treat it as though we are dealing with a stomach ulcer or cancer of the bowel or melanoma or gallstones or coronary artery disease. The process is so much more complicated that we simply don't have a way to break down and understand the functioning of the brain. That day may never arrive. And until the day that it arrives that we can actually do it, we would be better off acknowledging that we don't diagnose people and then say, what do we do instead? So before we get to what do we do instead, which I'm going to get to in this session, I want to say a little more about how desperately claiming that we're doing it sets us back rather than moves us forward. First of all, we have this book that masquerades as a manual of diagnoses, but there aren't any diagnoses in here, except some overlapping neurological conditions, which psychiatry loves to think or claim as part of what we do, but it's a tiny fraction of what we do. We deal with emotions and behavior, mental pain, performance or lack of it, bad habits, destructive behavior, all the very serious things. Emotions and mind cannot be reduced to medical diseases. So let me talk about a little bit about the way I see therapy working, where we give up on those ideas. And we don't try to diagnose the patient, we try to understand the patient. That means that when you try to understand somebody, you investigate. You come at it from a widened perspective, not a narrow perspective. The internist who suspects that you have gallstones doesn't think about the rest of your physiology unless there's reason to think that it's interacting in some way. For example, the gallbladder is right next to the large intestine. You might investigate whether the problem is really coming from the colon and not from the gallbladder. But you're still narrowing down your attention to that particular part of the body's physiology. And that's true throughout medicine. Diagnosis narrows the vision. In helping somebody with problems of the mind and the emotions and behavioral issues, widening the scope of your curiosity, widening the methods that you use to try to investigate, whether it's interacting with a person in some kind of talking therapy. I'm not going to try to advocate for one school or not. I've never been oriented to psychoanalysis. I've talked about that in the past. In fact, I really never thought that any one particular school attracted me. The model that I used was much too eclectic, borrowing a little bit from this and a little bit from that. But it's still all talking. That's only one way. People who criticize this part of psychiatry, they always want to create a caricature, as though you always have to do psychoanalysis and make these wild interpretations. No, it can be much more down to earth than that. But talking therapy, but heavens, that's not the whole field of helping somebody and investigating what is the problem. You may ask the person, do I have your permission to talk to your partner, your spouse, somebody else that is important in your life? Or maybe you may suggest, how about a joint session where you two people come in? Maybe a family session. Maybe you want to learn more about what's happening in their work environment. With their permission, you ask about that. You may need help to do this. Maybe you, as an individual practitioner or where you work, you don't have the ability to do that. You may want to bring in somebody who's a trained professional in what they do. Some kind of social work, some kind of in-home care sort of situation. Whatever it is, You simply try to learn about the person. Now, no matter how much you learn about them, you're not going to be making a diagnosis, because a diagnosis is when you find a scientifically verifiable cause of the symptoms. Well, you don't find causes in that sense for what's going on in people's lives. It's too complicated. I actually like to use the term soul of the person. What's their being, but not in a religious sense. I'll leave that to those of you who do that, and that's fine. But in my way of viewing, it's not a religious thing. To use the word spiritual or soul really speaks to the fuzzier side of life, the side that doesn't permit itself to be put in a scientific arena. And the minute we begin to think that we can only help people with things that can be put in a scientific framework, then I think we're limiting ourselves. So the therapist who thinks in this way thinks broadly rather than narrowly. Now here's another one that's very important, is that in medicine, symptoms are often a very good guide to causes, because we're talking about what we call pathophysiology. There's a sequence of events. The body, after all, is a lot of chemistry. And chemistry of living things is not totally separated from chemistry of non-living things. Atoms make up molecules, and molecules have configurations, and they interact with each other, and then you get to proteins, and biochemistry has rules, just like other kinds of chemistry. So when you do that in medicine, that's great, but in psychiatry, when you try to take the symptoms and infer what the causes are, you're doing just that. You're just inferring. You never can prove that your reconstruction or your picture of what is the cause is the correct one. And that's the critical difference between science and non-science. In science, you can prove that an idea is correct. You prove it by other people doing something that you've done, and you have measurements which are reproducible, and eventually you arrive at a data which speaks for itself. It's not a consensus alone. It's not a democracy. It's evidence which forces itself on the practitioners. They cannot avoid it. The evidence demonstrates it. Whereas in psychiatry, you were always going to have the possibility that people disagree. How will you ever resolve it? Yes, there is a way to resolve it, but not with science. And how is that? The patient resolves it by liking what you're offering them. Now, that's a big topic. It's an ethical quandary. Can people, when they're disordered, make good decisions about what you're offering? I did touch on this before. I just can repeat myself that in my view, while it is an issue that people in the midst of major problems are going to be compromised in those decisions, just like many other things, but they are the best that we have. They're the only thing we have that can really, truly put the mental health system to the test. The test of consumerism. And I tell you in all sincerity, I have no doubt in my mind that patients will tell us which treatments are working and which treatments are not. And treatments which patients are afraid of, unless they get sweet-talked out of it, like shock treatment, they will not accept it. Very few people will be willing to do it, and that will tell us something. That will tell us something not scientific, but it will tell us something in a human way that is the best that we have. And by not letting the patients be the ones who are the ultimate guide, and at the same time pretending that we have science to make a diagnosis, we will actually be creating a less humane and a less helpful vehicle by which to help patients and therefore help society. So consent becomes the successor to Doctor Knows Best and the successor to pseudoscience by not trying to think of it as science. Now, that doesn't mean that the psychiatrist should disappear. It means that medically trained psychotherapists or medically trained doctors who specialize in problems of the mind and problems of emotion will take advantage of the medical training that they have. And they will be well respected because that medical training is valuable. First of all, sometimes it can be a problem, whether you're a psychiatrist or another kind of medical doctor who deals with diseases of the body. Is this patient having a medical disease of the body? Or is this a psychological problem which does not have a physiological basis? I used to do quite a few consultations with internists, pediatricians, where there was a question, is this, they would be saying to me, we have worked the patient up and we cannot find a medical basis. We wonder whether this could be, as they say, functional. That's a term that, I don't know if it's used as much now, but it implies psychological as opposed to an organic basis. And so it's important to have somebody who has a lot of experience with emotional problems, but also has medical training, which a psychiatrist has both. So as a medical doctor, to consult with other kinds of medical doctors who can identify medical diseases, many times I would say to them, the pattern that I see, in my opinion, leads me to believe that there is a medical cause. But as a psychiatrist, not as an internist, not as a cardiologist, I don't have the skill to tell you what I think the medical cause is. You guys know more than I do about that, but I'm telling you, I don't think it's in my realm. So that was a useful function that I was just helping them with, and they would then continue on. Sometimes you end up where you think it's a medical disease, but you cannot find the cause. Then medical doctors have to deal with that. They may have to treat the patient just on the basis of symptoms. That is something that is legitimate for doctors to do, but they don't claim that they know the cause. So they're still within science. To say you don't know is a very scientific thing to say. So there's a role for psychiatrists there. There's another role with regard to medications. Now, as you know, I'm very critical of the way medications are being used, the vast overuse of medications, the fact that psychiatry has corrupted itself by allying itself with drug companies, that psychiatry has promoted its drug treatments as a way of rescuing itself as a profession, overlooking, as in a very strong way, the damage that those drugs can do. None of that means that there's never a situation where drugs under the proper conditions, it's not to say they could never be helpful. But number one, the patient would always have the ultimate consent. You would not be allowed to give people medication longer than they wanted or more than they wanted or despite how they feel. With all the problems that raises about their mental state, I say that it is the better way to go. The drugs are something that in the short term may give assistance to a period of respite, to a period of protection. In my experience, let's take psychotic breakdowns, schizophrenia as it's sometimes called. There's a prodrome or a period where the process is developing, but the person is not yet out of touch with reality, not yet at a place where you cannot hold a rational conversation with them. Very typically, in my experience, sleeping is a problem. Anxiety fears and chemical help to get to sleep for some number of days or even a little longer, I believe probably would help in reducing those kind of episodes or shortening the course, bringing them back where it's easier to work with them in some of the ways that require them to be rational. Because after all, if they're not rational, they can't tell you what kind of pressures they might be under, what's going on. They can't tell you what they think of things you might suggest and so forth. Now, if you think about this, talk about defending the patient's, requiring the patient's consent, I'm absolutely convinced that the most important thing in helping people with psychotic breakdowns is how quickly you interact with them. It's not as though suddenly you flip out and now they're gone. It's something that develops over days or weeks, maybe even longer. The fact that they had nothing to fear from psychiatry under the kind of system that I would propose, nothing that I can think of would allow them to come sooner, better than that, than knowing that if they come, they can leave again. They can stop seeing you if it's an outpatient situation. They can leave the institution if it's an inpatient thing. If it's a live-in facility, they are in charge. Why in the world would mental patients be afraid of psychiatry, as they so often are, if there wasn't anything to fear? I wrote an editorial once in, I think it was the Oakland Tribune, certainly not a peer-reviewed article. And if you're kind of person who wants to think that only peer-reviewed articles are worth anything, okay, but the title of my editorial was Fear of Psychiatry, It's Not Irrational. Psychiatrists today label a patient's fear of psychiatry or fear of shock treatment as a part of the illness. And how can you ask them to give consent if their illness leads them not to have the ability to consent? I don't think it's true that they can't consent. So what could help patients more than taking away the fear of the practitioners who would like to help them? And that's what I'd like to see. Practitioners who are voluntary, people in the patient's life, and any treatment suggested by the therapist would be not done if the patient, or only as long as the patient agrees, based on how they feel it. I've never seen anything in mental disorders that would lead me to believe that a patient does not have a pretty good sense of whether or not what you are doing for them is something that is good for them. There's a lot of things that they may not have very good judgment about, but I think they can sense whether this is something that they want and something that would be good. Maybe not in every case, but we don't have the luxury of designing any system that will always be perfect in every case. It's just not the way life is. So what do we end up with? We end up with patients who are always the ultimate decision makers, who have sometimes drugs recommended, but never for a lifetime, based on a diagnosis, which doesn't mean anything because there's no disease which has ever been identified. The drug would be recommended based on the understanding of the patient, which we gained by abandoning that medical approach and adopting this wide-based investigational approach, which is interdisciplinary, with psychiatrists, leading important figures, but not the be-all and end-all as is now. Using the talents of the people who come into the mental health professions in the ways that they can contribute, and not trying to be medical when we can't do it. Thank you very much. I'll look forward to seeing you next time.